We're at the 22nd CROI. I'm Fred Scheich with IFARA, and we're here with Stephen Grinspoon from Mass General Hospital in Boston. And we appreciate you taking the time away from a busy conference to do not only an interview with us, but a panel as well on cardiovascular issues. This is really a treat to have you take that time with us. So if you would, your presentation on statins, if you can cover that, that would be great.
Sure. Well, I'm an endocrinologist at Mass General Hospital. I've been studying the cardiovascular effects of HIV disease for a number of years. And we've learned a lot in those years about the special characteristics of cardiovascular disease and HIV, particularly the fact that these patients are relatively young and asymptomatic with atypical disease, including vulnerable plaque that's not calcified. And the plaque relates to immune activation markers more so than traditional risk markers. So it's a unique type of plaque in HIV. And when you think about particular treatments for cardiovascular disease and HIV, you certainly want to modify traditional risk factors, but you also want to use a strategy which might improve immune activation and improve that and other non-traditional risk factors. So we thought that perhaps statins might satisfy both those arms, risk factor arms, and they would reduce lipid levels but also modulate non-traditional risk factors. So we did a small study at the MGH, randomized double-blind placebo-controlled trial of atorvastatin, and the hypothesis was that the treatment group would have a regression of plaque in the coronary arteries. And to get at the coronary arteries, we used a technique called CT angiography, where we did a virtual coronary angiography without being invasive. We actually did coronary CAT scans and put the slices back together again to get images. And what we found is that the statin drug, atorvastatin, significantly reduced the regression of plaque and actually regressed plaque by about approximately 19–20%.
So it removed plaque from
it caused it to decrease in size, yes. It didn't remove it entirely, but it caused a reduction in the plaque volume versus the non-treatment group, which saw an increase in the plaque volume.
Do you think over time, over a long period of time, it would probably eliminate it? Or?
It's hard to know whether it would eliminate it. I think the more important question is, would that regression and decrease in plaque translate to an improvement in event rates? A small bit of plaque that's not particularly ominous looking or high-risk morphology might be fine. Many of us have plaque, but the question is, will the plaque turn into a ruptured plaque? And I think if we can prevent the rupture of that plaque, stabilize the plaque, then we've come a long way. And the interesting thing about our results were that not only did we show a reduction in the volume of plaque, we showed an improvement in the qualities and characteristics of the plaque. So the plaque was less vulnerable after statin.
Less likely to break loose.
Less likely to break loose, exactly. Good question. And so basically the attenuation of it, the fattiness of it improved, and the eccentric modeling improved, so the high-risk features improved. And that was interesting.
Do you have any people on Plavix also, which would maybe...
we didn't have anyone in that particular study on Plavix.
Because I personally am on Plavix, and I feel somehow or other empowered because I can...
Yeah, it does make sense, but we didn't study that particularly.
So do you suppose it would be the same for other statins?
Yeah, I think the statins, I think the expectation would be the same. Statins generally are uniformly good at lowering LDL, the approved statins in the United States. They have different characteristics in terms of their tolerability with different protease inhibitors, in terms of their effects on glucose, in terms of their metabolism. So I showed a slide, or Janet Lois showed a slide today, and I did as well, in which different statins are better or worse tolerated for protease inhibitor users. And the particular one we use, pitavastatin, has no known interactions with antiretroviral drugs and has not been shown to aggravate glucose. Now that study was chosen, that drug was chosen for the large study we're going to do, Reprieve. For this particular study that Dr. Lowe did, we used atorvastatin because we started the study 6 years ago, and that's what was available. Now we still saw some reasonable effects. We didn't see an aggravation of glucose, and we didn't see a particular interaction with protease inhibitors with atorvastatin, but there's a theoretical concern with atorvastatin, which is why for the larger Reprieve study, we would probably use pitavastatin instead.
Okay, and how different is that? How is that different?
So it's metabolized in a different way.
Oh,
it's
I see.
Not,
instead of the P450,
yes,
CYP3A.
it's
Yeah.
glucuronidated, so it has a much less theoretical interaction. Now again, we used atorvastatin in our study because that was what was available 6 years ago when we started the study. But if I was to pick a statin now, I would pick a more modern statin, pitavastatin particularly.
Do you have any other research that will manifest itself from this, or is this?
We have a lot of research using coronary angiography to describe morphology in different populations, HIV versus control. And as I said, we've shown at baseline that this type of plaque is occurring in HIV patients, even patients with low traditional risk factors. So the ominous thing is that you can't identify someone who comes into your office necessarily by using a traditional algorithm. You can't, the cholesterol may not be that high. They may or may not smoke. Smoking is very unfortunate, but even if they don't, they may have this manifestation of atypical plaque. And there was a study I presented today by Dr. Markella Hazani, which showed that under the new guidelines, 25% of patients with high-risk plaque would be recommended for statins, which sounds good, but the flip side of it is that 75% of those with high-risk plaque would not be recommended for statins under the current guidelines. So the question we're posing, which will be answered by Reprieve, is whether patients who don't meet guidelines for statins, whether statins would still be useful in that group to prevent cardiovascular disease. And Reprieve, which stands for Randomized Trial to Prevent Vascular Events in HIV, is a very large, federally funded study to get to the heart of the matter once and for all, whether statins will be useful to prevent cardiovascular disease.
In all people?
Well, we're studying it in HIV, but HIV patients, yes, who don't meet the guidelines for statins. So an asymptomatic 50-year-old without known cardiovascular disease may not meet the guidelines for statins, but because they have HIV, perhaps their risk is high enough that they merit it, and that's what Reprieve aims to answer.
Any other studies that you saw here at the conference that that jump out as, especially, I mean, are you working mostly in the cardiovascular?
Yeah, but I've kept an eye on the studies. I think some interesting studies were presented in the risk prediction session where the current guidelines may under-predict risk in HIV, and those studies are very important because they suggest that there are some risk factors beyond traditional risk factors which contribute to the unique pathogenesis of cardiovascular disease in HIV. I think those studies are very, very important. There were a number of studies in the cardiovascular session showing effects of certain drugs on renal disease, and some of the newer drugs may be less renal toxic, which is important, I think, because renal disease is a contributor to cardiovascular disease. So some of those new drugs may be very important with respect to cardiovascular.
You mean antiviral drugs or
antiretroviral drugs, yeah, TAF.
So that is really something to be learned. Do you have any? So what is your next step? What is your next research you're going to be doing?
Well, as I alluded to, we've gotten this large federal grant to try to prevent cardiovascular disease, but we have a number of other things we're looking at doing. We're going to look and see whether there's unique effects of gender on plaque and HIV, and we're going to look at whether there are characteristics of aging in women which may drive that. We have shown that women have unique markers of immune activation in HIV, and that may be an explanation why the cardiovascular event rate is relatively higher in HIV women versus non than it is in HIV men versus non-HIV men. So we'll be looking at gender. We'll be performing Reprieve. We'll be looking at Reprieve on not just effects on the heart, but effects on other HIV-related things, for example, liver and kidney. So maybe by the anti-inflammatory effects of statins, we could actually improve liver disease and improve renal disease and improve even AIDS-related events. So we're very excited to look at those secondary events. And embedded within Reprieve is a very large sub-study looking at coronary angiography, much like the one we presented today, but on a much bigger scale. 800 people, very definitive. And someone asked today whether there was a relationship between the change in lipid levels and the change in plaque. And there was a hint of it, but we weren't able to say definitively. But with Reprieve, we'll be able to definitively understand whether it's the change in lipids or immune activation markers or what that contributes to the change in plaque.
Where will that trial take place?
Reprieve will take place at approximately 100 sites, most in the U.S., but some in Canada and Thailand. And so we look forward to launching that in the very, very near future. I suspect within the next couple months, the first patients will be enrolled into the trial.
So if a person wanted to get on that trial, where would they look?
There's a website, www.reprievetrial.org, and I welcome anyone who is interested in the trial to go to the website. It's a public website, and we would encourage anyone to do that. On that website will be lists of all the sites that are participating, and hopefully we're geographically dispersed enough that you could find a site near you. Also, patients can contact us directly, and we can advise them of the nearest site to them. I think.
Are there any unusual inclusion or excluding criteria?
We are taking patients, HIV patients, between the ages of 40 to 75. So if you're below 40, the absolute risk of myocardial infarction is relatively low, and it probably doesn't merit the risk of that trial. We don't have good data on HIV patients over 75, though there are some now who are living longer, thankfully, that could enter the trial, but we're restricting it because the risk prediction algorithms don't extend beyond that age range. It's a very easy trial to get into. You have to be on antiretroviral therapy, but there's no specific cutoff for viremic viral loads or anything like that. So it's just being on ART with a CD4 over 100 gets you into the trial. And normal kidney and liver disease as well at the baseline to prevent any interaction with statins.
Okay, great. Anything else you'd like to impart here while we're on the...
No, I think it's an interesting time. We've learned a lot about cardiovascular disease and HIV, but we also have a number of challenges ahead of us, and I think we're working hard to overcome those challenges, and I think we're well on our way to hopefully preventing this disease in HIV patients.
Great. Thank you very much.
I enjoyed it. Thank you very much.
Appreciate it.
Thanks.